I would like to continue with the scientific strand, and I will try to keep it as concise as possible, focusing on radiation and how it has evolved all through the ages, and what newer options we do have now to treat even some complicated cases, or even from the early stage of the cancer to the advanced stages where the radiation is important, and what are the prominent aspects which we consider during taking case for the radiation. So we all know the gynecological cancers is a conglomerate which consists of cervical, uterine, ovarian, as well as vaginal and vulvar cancers. So most of the details about these cancers have been covered by my colleagues, Dr. Sachin sir as well as Dr. Harish. So I would like to directly go into the treatment part, where the radiation or the surgical, or what are the modalities that have been prescribed for these different types of cancers. Cervical cancer, we all know early stages of cervical cancer are always treated with a surgical intent, and surgery is always curative. And in cases where surgery is not amenable due to different conditions like medically inoperable or due to some anatomical differences, we do have an alternate for radiation to treat early stages of cervical cancers using external beam as well as brachytherapy. If you are going for locally advanced cancers, treatment is again in the early stages of local advance. You can either go for surgery or consider radiation, and as the disease progresses and becomes locally advanced, the treatment is always a combination of radiation as well as chemotherapy. When it goes beyond the stages of local advance into the metastatic disease, the treatment is done with the use of chemotherapy. Coming to endometrial cancers, is similar to cervical cancer. Early stages, always surgery is the primary point, and after surgery, if there are any adverse features or high risk features, then we can consider them for radiation. And if the disease has been advanced to even more to the nodal areas, then radiation along with chemotherapy can be considered. And in very advanced stages, again it will be palliative intent, either with chemotherapy, or sometimes we may use radiation to alleviate the symptoms. So in short, endometrial cancers, after surgery we can decide if there is low risk disease, we can simply go for surveillance, and if there is an intermediate or high risk disease, we can utilize the radiation with vaginal brachytherapy, and if it is locally advanced with nodal disease or extrauterine, treatment is done with external beam radiotherapy as well as concurrent chemotherapy. Coming to vaginal cancer and vulvar cancer, these are a bit rare, but still we do have implications how to treat them. And early stages, surgical management, and if you want to preserve functional as well as anatomical structures, we can go and consider for brachytherapy as well as external beam radiotherapy. And stage 2, stage 3, it's better to go with external beam radiotherapy, or sometimes you can consider for brachytherapy and concurrent chemotherapy in depending upon the stage 2 and stage 3. Advanced stages and with involvement of pelvic nodal disease, external beam radiotherapy along with concurrent chemotherapy is mainstay of treatment. And as with any other gynecological cancers, advanced stages always we treat with chemotherapy. So vulval cancer, it's similar to them, and most of the times we go for surgical management, and here the radiation is indicated either pre-operatively or post-operatively, and to minimize the extent of the surgery or to preserve the function. So this gives us the idea of which stage of vulval cancer requires which type of treatment. Especially you can see most of the times it is always surgery, and when the surgical margins are not possible and you want to decrease the size of the tumor and then go for surgical, then you have the option of going for preoperative radiotherapy. So we have been discussing about radiotherapy. What is the goal of radiotherapy? The main intent of radiotherapy is to maximize the cell death. At the same time, we would like to keep the normal tissues or the healthy cells to receive the minimum damage. So we have principle of ALARA as like as low as reasonably achievable. Based on this principle, all our treatment modalities have been designed, how much dose we have to give and how we have to spare the normal tissues around the primary disease. So we have seen the all gynecological cancers have a Similar modality of approach we have seen early stages, they go in broadly, they go for surgery, locally advanced, they go for radiation, very high burden of disease, or it's going to distant metastasis, it goes for a palliative treatment. So the radiation comes as an adjuvant post-operatively, and there you can utilize it for having decrease in local regional recurrence. And in definitive treatment, we can have organ preservation with radiation, and in very early stages, it can be considered as an alternative to surgery. And in palliative, to consider it for symptomatic control, so radiation is always utilized there. So during the last 2 decades, we have seen radiation has been evolved so much, and now we can see here radiation has been branched up into different things. Primarily, it is a teletherapy, that is radiation delivered from a distance, and the brachytherapy, that is radiation delivered through very near or the internally using the applicators. So you can see the teletherapy has now, because of the advancing technology, it has been changed, and newer modalities of treatment and techniques have been incorporated into radiation. You can see 3D CRT, that is 3D conformal radiotherapy, and IMRT, intensity modulated radiotherapy, and followed by image guidance have been come into existence after IMRT. This has been helping us to even more do precision radiotherapy. And more than that, nowadays there is one more concept of adaptive radiotherapy. And adaptive radiotherapy, precisely we are trying to adapt our treatment modalities or adapt our treatment according to the changes in the tumor as long as the treatment goes on. So we all know the tumor doesn't stay the same when at the start of the treatment and the end of the treatment. It keeps on going through some changes. It may shrink, or it may shrink homogeneously, or it may shrink in patchy ways. So these all changes now being incorporated into treatment planning. That is why we have come up with the concept of adaptive radiotherapy. And if this adaptive radiotherapy can be done in different ways, like offline radiotherapy, where we can try to see how much response has been done from the start of the treatment, and in between the treatment we can replan the treatment according to the changes in the tumor. And there is one more thing called dynamic adaptive radiotherapy. This takes up the changes every day in the tumor and the surrounding tissues, how the pathological as well as structural changes have been happening, and every day the replanning happens, and this can be done either automated or through offline. So stereotactic radiotherapy, this most probably we don't use in gynecological cancers, and this uses high ablative radiation doses to kill the cancer cells with very less side effects and shorter treatment durations. And brachytherapy, it is the internal radiation using brachytherapy applicators. Most commonly we utilize in cervical as well as endometrial cancers. And even brachytherapy has been evolved a lot from initial stages. We'll discuss later. So initially treatment has been done with two-dimensional techniques as well as 3D technology. Then later we have evolved into intensity modulated radiation therapy. What exactly it helps us? So for gynecological cancers, we do give pelvic radiation to prevent local regional recurrence and the extent of the disease. So what happens during pelvic radiation is we have to treat larger volumes of pelvis, which includes bowel as well as rectum, including bladder. So if these normal tissues receive higher amount of radiation, then the toxicities will be more even after radiation, and this after treatment quality of life will be affected in the later teens. So what IMRT helps is it overcomes this problem by reducing dose to the bowel, rectum as well as bladder. So it has been a novel approach after 3D conformal radiotherapy, and utilizes beams which have been divided from different angles and have been utilized in 3D planning to precisely target the region of interest. So it can also confirm the shape of the beams as per the target or the primary disease, and this helps in sparing of the normal tissues. And normal tissues can be spared. This conforms into decreased toxicity and better quality of life, as well as increasing ability to escalate the dose. So when you are able to save the normal tissues, we have a chance to try to escalate the dose and see if we can go for higher doses to have a better response to the tumor. So this shows The difference between the 3D CRT, the 3D conformal radiotherapy, as well as the IMRT plans. So on the right side, on the left side, you can see 3D CRT, as well as on the right side, you can see IMRT plans. As you can see, the 4-field box, how much radiation is going into the pelvic region, and the bowel, bladder, as well as rectum are coming into the higher dose regions. If the same thing has been planned with IMRT, you can see a lot of tissue for the bowel as well as rectum can be spared using IMRT techniques. With IMRT, you can decrease the acute gastrointestinal toxicities. You can see grade 1 toxicity is very low. In grade 2 is even more higher with the conformal radiotherapy. Coming to even late reactions, we can see they are higher with the conformal radiotherapy compared to latest techniques utilizing the IMRT as well as IGRT. And as you can see, the higher grades of toxicities are very, very less with the newer techniques. So after IMRT, we have come up with one more technique which allows us to spare the bone marrow. So we call it the bone marrow sparing IMRT. So pelvis has a lot of bone and bone marrow in the hip bones. So you can see that red region. So if you do planning with earlier techniques, 2D or 3D, lot of this bone marrow will receive radiation, and people may have effect of neutropenia and all. So now we have this bone marrow sparing techniques where we can precisely spare and can prescribe how much dose should not go into the bone marrows, so that we can spare the bone marrow and do a proper IMRT technique. So this shows how much percentage of radiation is going into the primary area as well as surrounding normal tissues as well as the bone marrow. As you can see, the normal tissues are being better spared, as well as concentration of the higher dose is going into the treatment region. So with these techniques, we can see hematological toxicities are very less with advanced techniques, and they are a bit more with the older techniques. So is it IMRT is like a fail proof? No. So we still have some concerns with IMRT, as people used to say like low dose radiation goes around into normal tissues around, but it has been more than a decade, and the chance or the potential chance of getting a second cancer with this low dose cancer is very low, as we have seen till now. So the next technique that has been evolved in treatment is the IGRT, is the image guided radiation therapy. So we have seen IMRT, how it is able to spare the normal tissues and how we can confirm the beams exactly in the shape of the tumor or into the precise target areas. So the image guidance has been added to this IMRT to help us even more precisely target the dose, target the regions, and how to spare the normal tissues. So it can improve the setup accuracy. So daily, it's like a radiation is not a single day plan. It is span across weeks. So every day there may be changes, and as well as like internal changes will be there, as well as externally on the setup there may be small errors. So to come over these problems, we have come up with image guided radiation therapy, which can improve the setup accuracy, as well as it can account for the internal target motions, which we can daily see on the images, and we can precisely plan for it. And it also helps in the adaptive treatment, as you can see, if like after some fractions of radiation, some people may have a lot of response to the initial treatment, and there may be changes in the primary tumor areas. So you can replan using this image guidance, and this helps in preserving normal tissues. So as I have said, the primary reasons why do we need IGRT is accuracy in the setup. So everyday setup can be verified using the image guidance, and this can help in precise radiation. So in the organ motions, like in gynecology, we can see uterus, bladder, bowel. These are like, there will be a lot of internal organ motion. So the same plan what we have done on the day one may not be suiting this treatment region or the normal tissue surrounding, and it's some other day. So if using IGRT, the image guidance, we can precisely see how these organs are there, and we can try to minimize the errors, like in which account for internal organ motion. So initially, without image guidance, we used to take larger margins so that we don't miss the primary tumor. So the other implication of this image guidance is for utilization the dynamic adaptive radiotherapy. So as long as you are able to see the changes every day using the image guidance, you will have an idea of if there is a tumor shrinkage or there is any changes in the surrounding regions. If you want to do a replanning, these all things can be helped by the image guidance. So you can see if using the adaptive planning for the radiation using image guided radiation therapy, you can almost decrease the toxicity to normal tissues. And as you can see, these are the plans with pre-RT as well as after few fractions of radiation. There is a lot of shrinkage with the residual disease, and so this, if you can replan, you will be able to save a lot of normal tissues surrounding, especially the small bowel. So after IGRT, the new concept that has been developed is the dynamic adaptive radiotherapy, as I have just told. Utilizing this image guidance and adapting our plans into our daily treatment things, utilizing the changes that have been occurring in the treatment area. So another concept is a brachytherapy, and which has been there from ages, and it is very important integral part of treating cervical cancer, endometrial cancers. Utilizing, there are different modalities of brachytherapy, especially the intracavitary, interstitial, and installational thing. So intracavitary brachytherapy and interstitial brachytherapy, we have different applicators for them, and depending upon the requirement, we utilize based on the staging as well as the tumor region which we want to cover after the external beam radiotherapy. So these are the initial modes of brachytherapy systems which have developed like 1 or 2 decades back. We utilized Manchester, Paris, etc. systems, Stockholm system, to know how to place these radioactive elements inside the applicator to get the coverage. So there used to be the brachy applicators with preloaded, then came the afterloaded, and then low dose radiotherapy has been evolved into high dose rate brachytherapy. So after initially we used to have a point year dose, like we used to prescribe to single point across in the pelvic region to have a dose prescription, and based on that we used to think that the dose coverage will be there for the remaining part of the target region after the external beam radiotherapy. But now the concept has been changed. Now we are utilizing this imaging concept to improve our brachytherapy, and this is called image assisted or image guided brachytherapy. And the modalities we can utilize for this are ultrasound as well as MRI, and sometimes we utilize the PET-CT also. So image guided brachytherapy is the novel approach in doing brachytherapy, and here you can see initially the residual disease along with microscopic surrounding disease will be there, and after your external beam radiotherapy there might be 3 types of responses. Either there will be complete remission, or there won't be any response, or there can be a partial response. So if there is a partial response, we don't know if it is a pathological response or if it is a residual response. So based on that, even a CT scan can show all these things, but an MRI can show all these differences, and we can clearly know where is the pathological disease, where is the residual gross disease. So based on these things, we have adaptive image guided brachytherapy developed. So you can see in the MRI pictures here, the initial first picture is the MRI at the time of the treatment start, and later you can see how the changes are occurring, and the spiculated part and the infiltrated part. Infiltrated part is where the parametrum is involved, and these things indicate where there is a pathological tumor or less residual tumor. So based on these things, we have different dose prescriptions for high risk regions inside the brachytherapy, and we can do a image guided brachytherapy with that. So these are the areas how we delineate using this information from the MR imaging, and give differential dosing with high dose, low dose, and intermediate dosing. So this is an example of stage 3B, which shows initially it was around 6 centimeters, and after external beam radiotherapy it has come down to around 4 centimeters. So there is a tumor shrinkage, and we can utilize this image guidance to precisely plan for radiation. So what are the future trends? So we have seen about IGRT and brachytherapy improvements. So are there anything coming new? So we do have MR-Linac. This is utilizing the MR-based imaging data to precisely plan for radiation. So its main aim is to dose fractionation as well as how to deliver the radiation and what is the efficiency. So it mainly concentrates on different locations, and inhomogeneous distributions can be addressed with this. So it has greater capability and functioning imaging. There are different series of MRI we can utilize in planning. They are diffusion weighted, dynamic contrast, as well as blood oxygen level and MRS. These can give idea of where are the proliferation, angiogenesis, hypoxia, and metabolism, and these all can be addressed during our treatment planning in differential dosing using the MR-Linac. So this is the construction of an MR-Linac, which shows how the MR is being placed, and the optimal dosing and tumor volume delineation can be done based on the differential types of series. So this is the workflow shown, and this has the capability to do a real-time adaptive radiation therapy utilizing the daily dose installation as well as the prediction for the future shrinkage of the tumor, and adapting the plan automatically as well utilizing even the biological information. So this is the MR-Linac example how it is being constructed and utilized. So it still has some implications, potential benefits, as well as some challenges to come out, and these have been being addressed, and it's like going to a practical now. So one more thing we have to definitely concentrate on is the flash radiotherapy. It's all about giving high dose radiation in fraction of second, so with very minimal effect on the normal tissues. So this is being in experiments with skin cancers as well as some other things which they are trying with electrons, and they have been showing very high promising results with very minimal toxicities, like even not even grade 1 or something. So you can almost deliver almost 150,000 gray in millisecond. So you can imagine treatment coming down to millisecond of a day instead of going for weeks. So these are the flash effects that takes consideration to dose rate more than 40 gray and per second, and that can be reproduced. And dose fractionation hardly needs 1 to 3 fractions. And radiation type, it is now being the normal linacs are being considered for conversion into flash radiotherapies, and that is more possibility. So this is the biological effect which utilizes complete oxygen depletion in the tumor cells. So that's why the higher doses can be utilized to completely kill the cancer cells, as well as the normal tissues are being spared because the redox biology is completely different. So we are looking forward for these newer technologies to come up for even gynecological cancers in the future. So these are the examples how the grade 1 response is there. So even utilizing the higher dose and decreasing normal tissue, which is close to our radiation principle of as ALARA, and this I feel going to be a future. So there are some advantages. We can decrease the duration time as well as spare the normal tissues. So some challenges still are there, how robust we can construct this, and how whether we can expand these things into other cancers as well as how the toxicities profiles can be checked for the longer durations. So one more thing that I would like to say before concluding is about the concept of radiomics that has been exclusively implicated now, especially in oncology, utilizing the artificial intelligence. So it takes up the data from MRI or the imaging modalities, whatever we have, and they can be fragmented into its different grayscales like intensity, shape, texture, wavelengths, and these all data can be gathered and can be utilized for prognosticating the disease, whether there will be a good response, whether which type of treatment is going to help this patient, and whether what type of response will be there and how long they can survive. All this data is being now modulated, and maybe it will be incorporated future. This concludes my speech. Thank you.